Malignant.
Only malignant, no benign behavior, but different degree of malignancy possible. Now we see if tumor only malignant, the tumor subdivided with a different degree of malignancy. It has more positive or less positive. No. Leukemia and lymphomas, what is the difference?
Leukemia is blood.
And those, where leukemia start?
Bone marrow.
In bone marrow. Those leukemia, this is tumor, which start in bone marrow. And don't wait. Lymphomas, this is tumor which start into the
Lymph node.
lymphoid tissue. And those, where are lymphoid tissue?
Peripheral and central.
Where else?
Lymphoid organs.
Spleens, like spleen.
Liver.
Thymus.
Intestines, toenails, maybe lymphoid organs also. And those in localization, peripheral lymphoid tissue is lymphomas. Though this is different. We'll start discuss about leukemia, tumor of the bone marrow. Those. How many genome steps of hematopoietic cells?
Five.
Those. Let's start. What is the first hematopoietic cell? Oh, pluripotent, some things. General stem cells, antiplatelet stem cell. Then undifferentiated stem cells are divided into the so divided into two different branches. Lymphocytic and myelocytes. Blood. Where? Blood. Where? Myelo. Blood. Precursor, general precursor from the myeloblast origin and the general precursor from the lymphoblast origin. Then, no, then the blast, the general blast, the myeloblast, and this is lymphoma. And then more differentiated blasts. There were differentiated blasts, not different blasts. More blasts. Erythroblasts, red blood cells. Megakaryocytes. Blast and later cells. Monoblast, you say. And the more differentiated myeloblasts also. And those lymphoblasts, T and B and T lymphomas. Now, the fifth steps in general, fifth steps, but different cancer cells have different stage of transformation. In general, called red mature cells. Some red mature cells. And then this last step is mature cells. What is the mature cells into the blood. Red blood cells. Next, platelets.
White blood cells.
No, white blood cells is other, no, red blood cells. Next,
Lymphatic cells.
okay, there is some stroma.
Macrophage.
Macrophage is outside, in blood monocyte. And later monocytes go out from the vessels and transform to macrophage. Next cells.
eosinophil,
Eosinophils, basophils,
Granulocytes.
in general, granulocytes. Such as neutrophils, eosinophils, and basophils. This is myelocytic region. This is self-myelocytic region. And lymphocytic region, what cells? What cells lymphocytic region? Lymphocytes, those subdivide into T and B lymphocytes, and B later transport plasma cells. And plasma cells produce immunoglobulin, antibody or immunoglobulin, Ig produced. And those acute chronic leukemias. Acute chronic leukemia is the name due to duration. And those, what is the outcome of leukemia? If we say it's malignant tumor,
destruction,
spread and facial death, that's due to complication. And those, what is the type of leukemia more dangerous, acute or chronic? Acute, because acute after short time lead to death. Chronic after long time, that can lead to death. More, and those the short time more dangerous. And those acute leukemias called if tumor cells immature cells. If tumor consists of the immature cells, elastic cells, that's acute leukemia. And chronic leukemias, if tumor develop from the mature cells. Chronic leukemias. And those acute leukemias can transform to chronic. If tumor cells stop differentiate, you think
no,
these cells can start differentiate again?
no,
No. In tumor tendency to anaplasia, to decrease differentiation, reduce. And those chronic leukemias can transform to acute. If cells, tumor cells differentiate, and then stopped differentiate, then we can divide. It's understand, no?
yes,
And those, this is step, the terminal stage of chronic leukemias called blastic crisis. When between tumor cells mature Increase. General. Leukocyte increase. And what is the variance of cells predominant? Blast cells. Because the tumor cells, blast cells. And into the blood test, you cannot reveal the fifth stage of cells. You can find blood cells in acute leukemias, and you can find few amount of the mature cells. Why mature cells can be found? If cells stop differentiating. Because mature cells has duration of life. If differentiated before, and now these cells not died yet. And few amount can be found into the blood. But in case of acute leukemia, the premature cells cannot be found. The name of this is changed. Hiatus leukemicus. The present blood cells, present mature cells, and absent premature cells. This is science for acute leukemias. It's science specific for acute leukemia. In general, how many blasts in peripheral blood? At normally, how many percent of blasts can be present in peripheral blood? No blast in peripheral blood. And not present one peripheral blast is bad. Can be up to 1% into the bone marrow. It's normal. In bone marrow, only 1% of the blast can be present normally. In blood cells. The other percent is premature cells. And those in case of leukemias, a lot blast in bone marrow, and this is blast in peripheral blood also. It's clear.
The premature version, normally it's in the peripheral blood or in the bone marrow?
In bone marrow. Premature cells sometimes can present in peripheral blood without leukemias.
Without pathological?
Without. If the patient has active inflammatory process, maybe. If from bone marrow, in case of reticulocytes also, it's rare mature cells for erythrocytes. In the reticulocytes also can present with anemia. Then the reparation of blood quickly. And this is the variance of when this is that pathology.
But not,
it's not leukemia. But in case of chronic acute leukemia, the present blood cells or absent premature cells.
in the bone marrow.
In bone marrow, many.
No, the absence.
Yeah, in bone marrow also. The same. It's clear. Those morphological change in morphological change classifications. About classification acute leukemias.
Acute monoblast, acute erythroblast.
What is the name of predominant blast? This is variant of leukemias called. No. If from the monoblast, it's called monoblastic leukemia. In general, acute leukemia is subdivided into two main parts.
Acute
Myeloblastic region and lymphoblastic region. And each of them subdivided into some subtypes. Myeloblastic, monoblastic, erythroblastic may be mixed together, mixed variants, if from the third type, that rare general myeloblastic region may be mixed together. And what is the name leukemia from the stem cells?
undifferentiated.
Undifferentiated. And those according behavior. behavior, undifferentiated, it's more aggressive or less aggressive?
More aggressive.
More aggressive, because these is cells not divide, not proliferate, not proliferate and not differentiate absolutely. It's absolutely undifferentiated variants of leukemias and more aggressive type, very short time, difficult to treatment, etc. Those and lymphoblasts also can be GB lymphoblastic origin. That's all. Morphological change. Morphological change due to leukemia develop because cancer into the blood. It's one position. And second position, absent normal cells. Because tumor grows into the bone marrow, and those what has happened with the normal cells died. They compress, destroyed, and some other process start, and the normal cells died. And those, what clinical symptoms and morphological change can be unit into some syndromes. The first syndrome, if red blood cells absent, what is the name syndrome? Anemia. And those, what is the change can be found in anemias?
Pale color skin.
Pale color. What also? If severe anemia. Anemia severe. Death of organs, cells. And those can be found in necrosis. Ulceration into the mucous membrane. Foci of necrosis into the internal organs due to severe hypoxia. The next, if platelets reduced, the hemorrhagic syndrome start. The syndrome called hemorrhagic syndrome. And those, what is the morphological change of hemorrhagic syndrome? Hemorrhage increase. Those. Petechias, what else? Hematomas can be. It's a malignant tumor. And we say malignant tumor has invasive type of the growth. And tumor leaf and blood and can destroy the vessels. Leukemic infiltration of the vessels can lead to massive bleeding. Sometimes massive bleeding can be cause of patient death. Hemorrhage in brain, massive bleeding, internal bleeding, or outside, external bleeding also. Those.
Doctor, massive bleeding, internal bleeding.
No, massive bleeding may be internal, maybe external bleeding due to injury of the vessels. As for example, can destroy and GIT tract bleeding, it's external bleeding because it's connected with the environment, and those it's type of external bleeding, such as the nose bleeding, it's also external, not internal, not okay. But sometimes can be massive and patient can die. Those next, absent granulocytes, infections, and those infections, spreading infections, phagocyte, no phagocytosis, and no microorganisms spread, and patient can have sepsis or septic conditions. Bacteremia, tendency to generalization, and patient can have sepsis. And also, the patient has repeated immune deficiency syndrome because lymphocyte, plasma cells also absent, and those repeated some infections and other symptoms, symptoms of immune deficiency syndrome, which we discussed at class of immune pathology. Those, together with this syndrome, there's some additional. There are localization of bone marrow.
Bone.
Type joints.
Joints.
Into the joints. The pain. And other syndrome, the hepatosplenomegaly. Because this is tumor leaf and blood, and also like, firstly, infiltrate the same organ, which can produce the blood. And those increase infiltration into the liver, hepatomegaly, and in spleen, splenomegaly, and enlarge of lymph nodes also. In severe case, any organs infiltrated by the leukemic cells, like as metastasis. Like as metastasis, but it's called leukemic infiltration, because it's lymph and blood. It's not spread, lymph and blood, it does damage any organs. And leukemic infiltration can be in any organs. And those, it's cancer, and additional problem with patient has cancer intoxication and cancer cachexia. And this is general effect for cancer also can be cause of that. Together with the previous gene.
Doctor, how toxification?
Intoxication and
And
cachexia.
cancer cachexia.
How
How intoxication?
smoke?
The tumor cells change metabolic. There's some products due to life activity of tumor cells. And these products can be toxins for normal cells. Intoxication.
Is this outcomes of leukemia? Cachexia and
It's not outcome. This is morphological change. This is general effect of leukemia. This is the possible cause of death. Outcome, death due to. Death due to some complication. If treatment start, the positive outcome possible. But should be treatment. Without treatment, no. It's malignant. Those about leukemias, clear?
Yes.
The chronic leukemias, same change but slowly development because the mature cell. And those in case of chronic leukemias classification also mainly subdivided into the lymphocytic origin and myelocytic origin. The additional group for chronic leukemias, monocytic leukemias, because in general, monocytes, it's not so many into the blood. The duration of life, monocytes, 1-2 days, and quickly die. And those leukemias, if leukemias develop monocytic origin, has more positive outcome to compare with the other kinds of the leukemias. Monocytic leukemias subdivide into chronic monocytic leukemias and chronic tumor from the macrophage. And the tumor from the macrophage called histiocytosis. Because macrophage go out. And histiocytosis, the behavior look like lymphoma. negative effect of the plasma cell disorder. Normal plasma cells, we see, produce normal immunoglobulin. Atypical plasma cells produce atypical immunoglobulin. And those due to atypical immunoglobulins accumulation in blood, hyperproteinemia, and what
Autoimmune.
complications start?
Autoimmune.
It's atypical.
Amyloidosis.
Amyloidosis. Do you remember what type of amyloidosis? Amyloidosis. Like
Essay. AA.
And so this is some additional details about this. Some details need to discuss and water. So, classification leukemias according number of leukocytes into the peripheral blood. Leukemic, subleukemic, leukopenic, leukemic. If severe increase, now more than 25,000 into the microliters and 25 and more, it's called leukemia. From 15 to 25, subleukemic. If approximately like the normal, how many leukocytes is normal? If this is can called leukopenic because the normal leukocyte decrease, typical cells. And
Absent.
Absent tumor cells into the peripheral blood and tumor cells present into the bone marrow. And number of general leukocytes severe reduced, significant reduced. Some question into the significant reduced. Now, the syndrome which we discussed. Symptom and syndrome of leukemia. Weight loss, why? Concentrated, fever, frequently infection.
Frequently monocytes, granulocytes.
Immune deficiency syndrome is the shortness of the breath. It's
Anemia.
result compensatory process
Anemia.
of anemia, hypoxia, weakness of muscles.
Anemia, blood supply.
Pain into the bones and the joints. We see human growth. Psychological problems.
Fatigue.
Because
Fatigue
anemia
is
and intoxication of the brain also. Lymph node swelling, we discussed why.
Infiltration.
Enlargement, spleen and liver, we discussed.
Infiltration.
Because it's primary, firstly, place where tumor cells like to grow except bone marrow. Extramedullary, this is organ extramedullary hematopoiesis. Those in this is always firstly start tumor cells growth. And the hemorrhages patches on the spots in the surface of the skin is result of the hemorrhagic syndrome. And we have discussed why it's development. Those classification, this we have discussed, classification, discuss. It's normal peripheral blood. Many red blood cells, few amount small doses platelets, and some in leukocytes, different variants of the leukocyte. In general, if you remember them in liters, erythrocytes it's 10 into the 12 degree, white blood cells into the 10, 9 degree. In general, it's 1 million times more. More. So this is the high magnification, also predominant red blood cells, some platelets, small, very small, and the different eosinophils, basophils, monocytes, neutrophils in this area. Acute lymphoblastic leukemias. What is the difference from the previous picture?
This one is more increased number of increased blood vessels.
the many cells, plastic cells, and tumor cells, we see it is the first class. The high nuclear cytoplasmic ratio, big nucleus, few amount of the cytoplasm. The number of these cells predominant to comparison with the erythrocyte. And this is key. No normal leukocyte in this area, not normal with some other defects in this area. Few amount of the red blood cells can be found together with the lymphoblastic cells. Is it so? Myeloblastic leukemia. Again, many atypical cells and not normal cells. The high magnification can reveal a few amount of red blood cells present and the atypical myeloblastic cells. The same change into the other variants. Chronic leukemias, myelocytic, lymphocytic, and monocytic origin. About monocytic origin, classification we discussed, and morphological change and more. The same, but it developed not frequently the some years, sometimes 5 and more years for chronic monocytic leukemia. There's some difference between chronic leukemias myelocytic and lymphocytic origin. Chronic leukemias myelocytic origin, the high question, one of the questions into the MCQ. Morphological change. Enlarge of spleen, hepatosplenomegaly predominance. To compare with the lymph nodes enlarge. In case of chronic lymphocytic leukemias, predominance enlarge.
Lymph nodes.
Lymph nodes. Hepatosplenomegaly also enlarge, become bigger, but not so severe. In case of chronic myelocytic leukemias, liver and spleen can be some kilograms, 5 or maybe 6 kilograms. So in case of lymphocytic leukemias, maybe 1-2 kilograms. It's also enlarged, but not so big. This one difference. Different organs predominant enlarge. Lymph nodes or hepatosplenomegaly. And those change of bone marrow. Granulocyte origin and into the peripheral blood can be found increased number of neutrophils, eosinophils, and basophils. In case of lymphocytic leukemias, only lymphocyte. No eosinophils, no basophils. Because it's not connected. It's absolutely different branch. And the change of bone marrow. In case of, do you remember what kind of inflammation develop if a lot neutrophils? Purulent. What color of purulent inflammation?
Yellowish.
Yellow. What color of bone marrow? Yellowish. The grayish yellowish color. It's called pyogenic because look like pus. In case of chronic lymphocytic leukemias, the intensive reddish color of the bone marrow.
Reddish color.
It's also few difference. Some details about different types of pathology, same pathology. This is bone marrow with the patients more yellowish.
In myeloid, it is reddish.
No, lymphoid,
Lymphoid
reddish, dark reddish.
That.
Grey yellow myeloid.
And yellowish grayish for myeloid. Because neutrophils. And neutrophils for the pus. Those. Change of the spleen. Also with some difference. In case of myelocytic leukemia, like us here, myelocytic leukemias, the tumor cells deposit into the red pulp. In case of lymphocytic leukemias, the tumor cell deposit into the white. lymphoid follicles. It's more likely for the lymphocyte. The myelocyte outside of the lymphoid follicles. There's also some details, different details. The new variants of workbook and old variants of the workbook contain different type of details. And previous tables, there's some differentiation of acute leukemias in new variant of the work. The difference between chronic myelocytic leukemias, lymphocytic leukemias, and difference between different types of lymphomas. Different variants of workbook, different variants of the tables. Change of bone marrow we have discussed. Few slides today, liver in myeloid leukemia. This is one of the control slide, not exam, controlled only. And those between liver hepatocytes. Between the hepatocytes, you can find many tumor cells. Of course, the tumor cells, it's leukemic cells, tumor cells. The same change can be found in spleen. You pick that is photo, you slide, and many, you should draw the many tumor cells between hepatocytes. Chronic leukemias, we see enlargement of lymph node predominance. All group of lymph nodes enlarged include enlargement follicles into the intestines, spleen enlarged, and start enlarged from the lymphoid follicles. Enlargements in direct lymph nodes and other peripheral lymph nodes become bigger and large. This picture shows periaortic lymph nodes enlarged. The normal size of periaortic lymph nodes approximately 0.5 centimeters. Now, and this picture shows many centimeters. It grows, start aggregate together, consolidate together with a big patches formation. And the bone marrow, we say it's the reddish color, intensive reddish color. There's some details about multiple myeloma. In case of multiple myeloma, they are atypical plasma cells, we say, produce atypical immune globulins. And this is atypical immune globulins called paraproteins, atypical proteins. This is atypical proteins can activate osteoclast cells. And what is they doing osteoclast cells? Blasts. Bone formation blasts.
Death.
This is blasts.
No, matured.
Osteoclast cells.
Lysis.
Lysis. Destroy. Lead to bone destruction. And those multiple myeloma associated with the destruction bones. And result hypercalcemia. Also the some details. And those tumor starts grows into the compact bones, the skulls, spinal column, ribs maybe, thorax. And due to resolution, due to lysis, bones can be found empty place, which complete with the tumor mass. This picture, this is photo. The skulls bone destroyed and reddish jelly mass complete the field. This is area, and this is also. This is not bone. This is cartilage. This is cartilage, and this is cartilage. And bones was before here. The bone destroyed and replaced by the jelly mass. And progression of this pathology can lead to the pathological fractures of the bones. And deformity into the spinal column deformity also can progress to the compress important organs, nerves, can progress to some other more severe problems. Compress the nerves which provide the spinal system, compress nerves which provide the heart work. X-ray examination can reveal empty place, complete resolution, resorption of the bone. Those empty places. This is also plasmacytoma, plasma cells, tumors. This is again skulls, but previous picture before X-ray. From the internal lace, from the dura mater, this is outside from the skin. The skin removed and the on surface of the skulls bone can find the some tumor mass. Tumor mass, reddish color. Microscopical examination revealed plasmacytomas, plasma cells, many plasma cells. Light chain immune globulins, immune histochemical stain reveal a lot light chain immune globulins inside of this is plasma cells, tumor cells. And results, amyloidosis. And those kidney reveal hypercalcemia, hyperproteinemia, amyloidosis associated with the aggregation of proteins together and blocked tubules into the kidney. This is a typical aggregation of these proteins called Ben-Jones proteins. And has name Ben-Jones proteins. And can lead to the complete obstruction. Tubules from the one side